Welcome to this Step 3 review on inpatient infections. This video is brought to you by Roadmap to Residency. Today we cover hospital-acquired pneumonia, Clostridioides difficile infection, line infections, and antibiotic stewardship. Here is the important part. We are not going to reteach these diseases. We are going to show you how the test writers build the stems and how you attack them. Each of these topics has a signature stem, a buried detail that decides the answer, and distractors that look thorough but are wrong. Work through this alongside your question bank and a trusted review resource. Let us get started. Here is our plan. First, you will learn the signature stem for each topic, so you can name the diagnosis before you look at the answer choices. Second, we will train you to hunt for the detail the writers bury in the middle of the paragraph, which is almost always the hospital day, a device, or a recent antibiotic. Third, we will walk through 4 stems and eliminate every wrong choice out loud, because knowing why a choice is wrong is what protects you when 2 answers look reasonable. This video assumes baseline knowledge from your review resources. We are here to sharpen how you take the test. Strategy 1 is to count the hospital days before anything else. Find the admission, then find where the symptoms started. Pneumonia beginning after roughly 48 hours in the hospital is a completely different disease from the pneumonia the patient walked in with. Different organisms, different antibiotics, different answer. The writers know this is the hinge, so they hide it mid-sentence, in phrases like on the 4th hospital day. Train your eye to find it first. Second, devices are never decoration. If the stem mentions a central catheter, a urinary catheter, or a breathing tube, that device is telling you the likely organism, and it almost always appears in the correct answer as something you remove, exchange, or deliberately leave alone. Strategy 2 is to culture before you cover. When a patient is septic and your choices include starting antibiotics and obtaining cultures, the answer is usually to obtain cultures and then treat without delay. Be suspicious of any choice that starts broad antibiotics and never mentions a culture, because you have made the next 2 weeks of care guesswork. Be equally suspicious of one that waits for results before treating an unstable patient. Now the second half, and this is where people lose points. For Clostridioides difficile, the most tested trap is testing a patient with no diarrhea, or retesting one who is already improving. The test detects carriage, not cure. If the stem says the stools are formed or the patient is better, the answer is almost never another stool test. Strategy 3 is antibiotic stewardship, which appears more often than people expect. First, narrow the moment you can. These questions have one setup. A patient is improving on broad coverage, and a culture returns naming one organism with its sensitivities. The answer is to narrow to the drug covering that organism. The trap is the choice that continues broad coverage precisely because the patient is doing well. Second, when a stem hands you a sensitivity panel, treat it as an instruction, not scenery. Match the narrowest effective agent and move from the intravenous route to the oral route once the patient is stable and eating. Third, beware the overkill answer. The writers plant something impressive, like adding a second antifungal in a patient already getting better. Doing too much is wrong just as often as doing too little. Our first question. A 68-year-old man was admitted 5 days ago for a hip fracture and had surgical repair. He now has a fever, a new cough with thick sputum, and a rising white blood cell count. He needs more oxygen than yesterday. His chest radiograph shows a new infiltrate in the right lower lobe. He has received no antibiotics this admission. Before you look at the choices, find the hospital day and ask what that single detail changes about the organisms you fear. Commit to an answer, and we will reason through it next. Let us break this down. Spot the pattern. The infiltrate appeared on the 5th hospital day, well past that 48-hour mark. That one detail converts this from the pneumonia you see in clinic into hospital-acquired pneumonia, where the organisms of concern are resistant hospital flora. And he is deteriorating because his oxygen requirement is climbing. Apply the rule. Obtain cultures, then begin antibiotics covering resistant organisms without delay. The cultures let you narrow in 3 days. The prompt treatment protects a patient getting worse in front of you. Now eliminate. Oral azithromycin treats the wrong disease, and the hospital day told you that. The computed tomography scan is your overkill trap because the radiograph already showed the infiltrate, so the scan delays treatment without changing anything. Observation is unsafe when oxygen needs are rising. The answer is obtain cultures and begin broad antibiotics. Our second question. A 72-year-old woman is on the 7th hospital day of treatment for a skin infection with intravenous clindamycin. She now has 6 loose stools a day and mild lower abdominal cramping. Her temperature is slightly elevated, but her heart rate and blood pressure are normal. Her white blood cell count is only mildly elevated, and her abdomen is soft and not distended. Her stool test for Clostridioides difficile is positive. 2 details do the work here. Find the drug she is on and take inventory of how sick she actually is. First, find the offending antibiotic. Clindamycin is a classic offender, and the STEM did not place it there by accident. The first move in every Clostridioides difficile question is to stop the antibiotic that caused it, if the underlying infection allows. This step is so easy to skip that the wrong answers are built around skipping it. Second, judge severity before treating. Her vital signs are stable. Her abdomen is soft. Her laboratory values only mildly abnormal. That is not the severe or fulminant picture. So stop clindamycin and begin oral vancomycin. Now the distractors. Adding loperamide is actively dangerous because slowing the gut traps toxin and it leaves the cause running. The scan with surgical consult is the overkill trap, planted for a patient with a soft abdomen and stable vital signs. Repeating a positive test changes nothing. The answer is stop clindamycin and begin oral vancomycin. Now line infections, which have the most recognizable stem on this list. The signature setup is a patient with a central catheter who spikes a fever, and the stem quietly rules out every other source. No cough, clean urine, no wound. When you see that, draw cultures from both the catheter and a separate peripheral vein. 2 cultures, 1 peripheral. A choice that draws a single culture or pulls the line before any cultures is incomplete, and the exam offers you both. Now the part that decides most of these questions, which is knowing when the catheter comes out. The stem tells you by naming the organism or painting the picture. It comes out for Staphylococcus aureus, for Candida species, for severe sepsis, and for a tunnel or exit site that is red and draining. A stable patient growing a common skin organism may not need removal at all. Our third question. A 54-year-old woman receiving chemotherapy has a tunneled central catheter. She develops fever and shaking chills that begin shortly after her catheter is flushed. Notice how the stem clears the field. No cough, clean urinalysis, no wound, and the skin over the exit site looks normal. Blood cultures drawn from the catheter and from a peripheral vein both grow Staphylococcus aureus. The organism is doing all the work in this question. Pick your answer, and we will go through all 4 options. The organism is the answer. Fever and chills timed to a catheter flush, with every other source deliberately excluded, is the signature line infection setup. Both cultures grew Staphylococcus aureus, and that organism means the catheter comes out. So remove the catheter and begin intravenous antibiotics. Notice the detail planted to tempt you, which is that the exit site looks completely normal. A normal exit site does not spare the line when the organism is Staphylococcus aureus. Now the key distinction. Treating through the catheter leaves an infected device in her bloodstream, inviting relapse and seeding to her heart valves and spine. Exchanging over a guide wire places a new catheter into an infected tract and is wrong for this organism. Oral antibiotics without patient follow-up dramatically undertreats bloodstream infection in a patient on chemotherapy. The answer is remove the catheter and begin intravenous antibiotics. Our final question, and it is pure stewardship. A 60-year-old man was started on the broadest available coverage 3 days ago for hospital-acquired pneumonia. He is now afebrile, his white blood cell count has normalized, he is on room air, and he is eating. His cultures grow 1 organism, sensitive to a narrow agent. See how the pieces fit. A patient who is better, plus a culture naming the organism, is the signature stewardship setup, and it is asking you to narrow. Choice A, narrow to the agent the sensitivities identify, is correct. That is the entire reason you drew cultures. Choice B, continue broad coverage until discharge because he is doing well, is the trap most people fall for, because it feels cautious. It is not. It drives resistance with no benefit. Choice C, add an antifungal, is your overkill answer. Choice D, stop all antibiotics today, ends the course far too early. The answer is choice A. And while narrowing, remember a stable patient who is eating can often move to the oral route. That wraps up inpatient infections. Lock in the core ideas. Count the hospital days first, because pneumonia starting after about 48 hours is a different disease with different bugs. Treat every device as a clue, never background. Culture before you cover, and never test the stool of a patient without diarrhea or retest one already improving. For line infections, draw 2 cultures with 1 peripheral and let the organism tell you whether the catheter comes out, which it does for Staphylococcus aureus, for Candida species, for severe sepsis, and for an infected exit site. For stewardship, narrow the moment sensitivities allow, because continuing broad coverage in a patient doing well is a trap, not caution. Drill these under timed conditions and read every explanation, even on the ones you got right. Your review resource has full chapters on each of these infections. Visit roadmaptoresidency.com for expert tutors and residency advisors who can build you a personalized study plan. If this helped, please like and subscribe so you do not miss our next board review session. Good luck on your exam, and we will see you in the next video.